at this moment in time. So I'm really delighted today to welcome everyone to our Let's Get Technical call. It's really it's a kind of a broader topic today. I would say it's a global topic. As over the months that we've been holding these events, we've expanded our view domestically within the U.S. across a variety of topics today. For a variety of reasons, we're expanding our view across the world, so I'm excited about that. I've got a couple of introductory comments to make and a little stage setting, and then we'll dive into it with our wonderful presenters here. So, Mike, if you'd advance, please. We have housekeeping. I think that it goes for not to have to provide any instructions. Everybody is too well aware of this. There are a variety of ways, as you know, to engage in the conversation through the chat. We'll be tracking that hopefully closely and try to respond to thoughts around that. You can raise your hand, and you can also clap and some of the wonderful little icons that Zoom is now presenting to us. We're hoping to get, and we're encouraging you to participate in the conversation. It is being recorded, like all of the other, I think 45 or 46, if I'm correct, Sundays webinars we have. So feel free if you have So if you have a lousy weekend weather, feel free to binge watch all weekend long. It'll give Game of Thrones a challenge there. We're also live streaming on YouTube here. So welcome, folks. Move to, thanks, the agenda. So today's agenda really is to talk about global perspectives from the EU and Eastern Europe and Canada and the United States and wherever else people are hailing from. And we have three terrific presenters, Dr. Karen Smith, who some of you may have heard already. She's deeply involved in the work. Former director of the California Department of Public Health, Alfonso Laura Montero, the CEO of the European Social Network. And it's kind of like I would say it's similar to the American Public Human Services Association. So it's an association of states and countries across the UN, and Alfonso will give us more about that. And Dr. P.G. Forrest from the Calgary School of Public Health, Public Policy. I'm sorry. So go next, please. And so next week, just briefly, we have a wonderful presentation by Marianne Yeager from the Sequoia Network. And for those of you who are interested in the whole federal effort to the accelerator efforts and a lot of the big efforts going on to rationalize healthcare IT development, Marianne has been a real driver in that across the nation and is now leading the effort for the recognized coordinating entity. So it fits with the Gravity Project and Karen and Da Vinci and Argonaut and the PASS project. So she's agreed to share a little bit of what the Sequoia is doing and how it syncs with the rest of the work we're doing. So put that on your calendar if it's not already there. And we're looking forward to sort of connecting the dots between some of these federal initiatives. And next, please. So we're going to do just two quick polls here. We're going to ask you kind of what areas you focus on most. It's good for our presenters and everyone else on the phone to see kind of what the distribution of areas of interest are. So Mike, if you could run that poll and just choose as many as you like and submit. We'll just do this, see how quickly we can do this.
We're over 50%.
Okay, another minute or two here.
Last call. Got another 10 seconds.
Let's see what we got.
Okay. I'm sharing that now.
All right, so we have a good, actually we have a preponderance of public health. Points to Karen for attraction of public health. Human services and healthcare actually healthcare IT is slightly ahead of human services. Our colleagues from education are showing up, and our public safety, emergency medical response, and others are pulling up the rear here. So good distribution. We got to figure out how to get more public safety in these conversations as well, but it's a good start. So one more question about, Mike, if you show the next one here, just from a regional perspective, and if you are not from any of these regions or out of the country, feel free to add where you are in the chat and just get a sense of where people are hailing from today. And I know our friends from Texas always identify that they're from Texas. So I guess we have to add a separate category there.
Let's see, we're over 50%. Give it another 10 or 15 seconds.
Okay. Okay.
And
all right, Esther. España. Good to see you online there. Mike, what do we got?
okay.
All right, I guess it's a little early in the Northwest for folks out there. Maybe it's was partying too much last night. So as you can see, obviously, pretty good distribution of folks from across the country. We'll have to chat up our friends from Seattle and Oregon and Idaho next week, make sure they're represented here. So good representation. Other folks from outside of the US, feel free to let us know where you're from. And we can move forward on this one as well. Mike, thanks. So just briefly, I think this is, I've spoken, of course, about the NIC in the past quite a bit as an introduction. There are some new people on the call here. It's important as we think about in my opinion, as we think about the impact of the global pandemic, how we're coordinating across the various networks that are working to address this. And that's really at the core of the National Interoperability Collaborative, is not only how do we focus on individual segments, but it's really the cross-sector work that we're really focused on. And we're incredibly grateful to the Kresge Foundation for recognizing that and sponsoring and supporting that work over the years. And I think today is another example of what we try to strive for, is looking at the connections and ways that we can really learn from one another, both across our disciplines and domains, but also across the world. So I encourage you to look more into that if it interests you. And one more thing, if you go forward. Now this is, again, I've spoken about this in the past in terms of our national action agenda, which is for stewards and our partners and the other stewards on the call here. It's really an effort, it's almost a clarion call to say, what are we going to do over the next 9-10 months? What is COVID sort of allowing us or calling us to do in terms of a response to this unprecedented pandemic? And the fact that it's presenting a paradigm shift, I think, in all of our lives. We talk about those words frequently in terms of an inflection point or a moment of change, or literally a paradigm shift. And I firmly believe that we're in the midst of that. Things are not going to look like the way they look today down the road a bit. And so we proposed a national agenda to identify a few things that would really make a difference to the trajectory of our infrastructure, our ecosystem, health and human services as we go forward, and are now aligning and bringing people together around these conversations. We'll be kicking this off more formally in early July with our colleagues from Stanford School of Medicine and the Center for Population Health Science, as well as others across the country. And we invite you to participate. We're looking for voices and people who want to contribute to various aspects of this conversation, whether or not it's racial equity, justice, technology, privacy, confidentiality, interoperability. All of those topics we're going to be trying to bring together, synthesize those, and come forward with a very actionable roadmap as we go forward. I've come to believe recently that interoperability, information sharing is really at the crux. It's one of the contributing drivers for equity, I believe, and for social justice. Knowing what the needs are, what the opportunities are in excruciating detail, while it does have risks, of course, is a way for us to be able to allocate and to be able to provide services and supports and to people who need them, under-resourced kinds of communities. So we'll be talking more about that. But I feel like it's one of the really strong levers and drivers for change. And we certainly are committed to that and supporting that in our work and with others in the larger community of networks. So if you move to the next slide, and you can sign up here. Just a few slides just to set the context. As folks have known now, probably from lots of presentations and communication about our health system and the inadequacy of some of our response public health wise, some of the statistics are outstandingly outrageous in terms of the fact that we're spending nearly twice as much as most other countries in terms of our healthcare, and the outcomes and the results are not necessarily commensurate with the spend. So Mike is just going to run through the next 3 slides here, just to point out that in terms of our HHS spending, human services is really about 15% of the $1 trillion plus budget, with Medicare and Medicaid representing about 85%. And the other 15% are between discretionary programs and other mandatory programs and children's programs. So in terms of balancing with social determinants, certainly health is critically important, but it is a clearly disproportionate investment in spending, which I think we're hearing more and more in some of the conversations around policing and the allocation of resources to community services. As we look at the investments, maybe there's some opportunities to shift some of those dollars. In terms of outcomes, Mike, go to the next slide. We have one back up, please. Oh yeah, next one down. We have so a claim to fame. We have the lowest life expectancy out of the OECD countries. Next, we have the highest rates of obesity in the U.S. off to the right there. Next slide. We have the highest suicide rates amongst the same countries, same group of countries, and highest chronic disease burden. So next slide. So you can get all 4 at once on this. So it's a challenging situation. How and what we do with our expenditures, our enormous expenditures, are, in my opinion, not necessarily driving the kind of results that prevention and orientation would hope to bring us towards. It's a complicated issue, I know that, and this is really in some ways part of the drive for today's conversation, which is, how do we do things differently? Can we do them better? Does coronavirus provide an impetus for us to change the way we're thinking about this work? And so with that, I want to sort of pivot into our conversation today and go to the next slide. And so, as I said before, our three speakers, and the way we've designed this is each will have about 15 minutes or so to sort of present a little bit of topical discussion with some room for questions, and then we're going to reserve a bunch of time for discussion to go into some of these topics in greater detail. So we really do encourage your participation and thinking, both during and following the presentations. And so I'd like to ask Karen to just give us a kind of a perspective on what the world is looking like now, from the great state of California and beyond.
Sure. Thank you, Daniel. I'm actually hoping not to use anything close to my 15 minutes because I'm really eager to hear from our international colleagues, boots on the ground, what things feel like and look like there. But I think everyone in the audience is well aware of the sort of major happenings around coronavirus. We are in the United States, we've only just been surpassed as the country with the most coronavirus cases, unfortunately, by Brazil. And deaths continue to climb, although somewhat more slowly than they did previously. That said, I think the most disturbing things that we are seeing in the US right now are the increases in cases in almost half of the states in the United States. Those are predominantly states that opened their, or we'll just say lifted their mobility restrictions earliest, although not entirely. California continues to climb, largely driven by the situation in Southern California and Los Angeles, the only really large population compared to places like New York, Chicago, Houston, et cetera. That said, what we are at a point in the United States where we've come to something of a, it's not really an impasse, but we're looking now very clearly at, it's not just theoretical that when you start to lift restrictions, cases increase. We're seeing it every single day. Even in little Napa County where I live, we had a sharp spike. It's a small spike because we're a very small community, in direct result of people's activities over Memorial Day. And this is playing out on a large scale across the country, not just because measures have been restricted, though that's a key player, but now we're in the midst of a huge level of political upheaval and going into, I think, the 14th day of large demonstrations and rallies where we're seeing many people on some days, millions of people in close proximity for prolonged periods of time, often without masks and often engaging in chanting and things that increase the likelihood of viral transmission. So it's inevitable that we will continue to see increasing cases of COVID. The question being for most of us who work in public health or healthcare is, are we going to be able to keep up in terms of the healthcare system? And we have done amazing efforts have been made to increase contact tracing, but contact tracing is inherently a slow and labor-intensive process and not in and of itself able to mitigate the transmission of disease. So, but the political reality is, and there's there's increasing validity to it, that the intense mitigation measures, the strict stay-at-home type orders has had a devastating impact on the economy. And that impact is increasingly likely to continue over time. And so we have reached the point that virtually everyone that I know who's been planning for pandemics for quite a long time has always predicted we would reach a place where people and the political establishment simply couldn't afford to continue to do what we know is the most effective thing in stopping transmission. And that's the point we've reached. In fact, I think in most places, we've passed that point. So we're pivoting or attempting to pivot now to how can we mitigate the lack of mitigation, if you will. What things can we do? We actually know that you can open safely. It's a question of will people wear masks? Will people do their very best to stay 6 feet apart? Will companies actually invest in what it takes to create the physical infrastructure to do that? It would help if we had some strong national leadership that could both articulate what's needed, but also show compassion for people. In terms of the impact of the most profound impacts of the pandemic, like everywhere else in the world, in the US, it has been overwhelmingly, what it's done is demonstrate not just the existing inequities in our society, but it's worsened them considerably. Everything from the fact that the physical effects, the actual disease process is more severe in people who have certain conditions, for example, obesity, etc., chronic diseases that are more prevalent in our under-resourced communities, in our people of color, than they are in our well-resourced, overwhelmingly white population. That has, and in addition to that, those people who are most effective are also those who have the least access to the highest quality healthcare, although some of that has been leveled a little bit. But in addition to that, the fact that even those people who don't have COVID have been forced to delay care for chronic conditions with what we predict will be significant and measurable long-term consequences. People with chronic heart conditions who aren't getting the level of care that they would have otherwise for a variety of reasons, everything from outpatient clinics being closed to lack of transportation, lack of health insurance, et cetera. And certain populations, and particularly the elderly, are disproportionately impacted, even if they don't have just by the mere fact that their age is a precondition to more severe outcomes if there's COVID, but they're also very vulnerable to isolation. And isolation, particularly for those who have limited financial resources can be profound. They often don't know how to do telehealth, so their access to healthcare is actually even worse, or they don't have the ability to. They don't have internet. Why would they have internet? They don't have a computer. We're seeing increasing rates of depression, anxiety, and in a not yet well measured, but very clearly present worsening of mental decline. Whether that mental decline will reverse or whether it will just continue to progress, leading to earlier deaths, we don't know. Summing up sort of the overall physical effects of COVID, what we know from the death rate, it's not just elderly in SNFs who are waiting to die. Anyways, I'm sorry, skilled nursing facilities who are waiting to die. But overall, across the population, what we know is that people are dying of COVID on average 10 years earlier than they would have. And that's at every age. So young people in their 20s are dying 10 years before they would have, or more. So the physical impacts are tremendous, but then the impacts of mitigation measures themselves are also going to accrue over time in the same way that we're going to see long-term effects from the physical consequences of COVID. We already know that, or suspect in most places and know in some places from measurement, that there is likely increased rates of child abuse, but the rate of reporting of child abuse is down, plus the workforce available to respond is less. We're likely also seeing longer stays in foster care and youth who are incarcerated because of the lack of the ability and the workforce to get folks out of those situations. We know that vulnerable children, in particular children in poverty, have lost meal access. People are in communities making heroic efforts to try to replace those school-based meal programs, but they're not able to do it for everyone, and particularly children who also have transportation issues. And so the kids who have fewer resources also there's a lot more research coming out now about how much less benefit they get and how much further behind they're falling through our attempts at keeping kids engaged in school at home. Often these kids have no or slower access to internet and computer equipment. They may also have parents who are working. Disproportionate numbers of our essential workers are people of color and people from low-income communities because we don't pay them very much. And those families are either not present with their kids, or they may have low literacy, or they may have language barriers to the materials that are coming. That loss of educational growth and attainment in children is going to have lifelong impacts. There's no question. We already know that that's true. It's one of the most foundational of all the social determinants of health. And single moms, here's another population that has been disparate. Many single moms are in fact essential workers. If they're going to work, who's taking care of their children? Particularly since we've limited childcare. So, I could go on and on. I think most of you, there's a substantial number of you who, from public health and social services, who are well aware of these, who don't really want to get into a litany, but I would just add some compounding factors. As we start to see the inevitable impact of the downturn in the economy on government it was always a sector that gets hit hard when the economy tanks. During the 1980s, or the 85 recession in the US, I was working in public health. We went through 14 rounds of budget cuts in a 2-year period. And what you cut when you're cutting in health and social services, as all of you in the audience know, are people, because that is our biggest resource. That means there are going to be fewer people available to try to implement and to try to utilize any resources that do come in to address some of these social issues that are developing in our societies. So there is no doubt in my mind that we are going to see long-term measurable effects on people's economic mobility and stability, and with all the downstream consequences that that has. The question is, are we going to be able to measure it? Are we going to be able to tell where those things are most acute so that what limited resources we do have, we're able to target? And that's where I think the work that Nick and others are doing on creating interoperable data systems that allow us to measure things that are not health, that are not public health directly, not disease, but also social factors, and use the resources of sort of advanced AI and machine learning to really help us understand where to target the limited resources that we have in order to have the greatest bang for the buck. And so I'm going to stop there, and happy to take questions. I don't know, Daniel, are we doing that just by chat, or are we going to open up, or move to the next presentation?
Yeah, we can. If there's I think for me, I think you covered sort of the situation, and then the potential impact, the likely impact downstream, and how do we position ourselves for the future, the inevitable future of budget cuts, reduction of services, reduction of personnel. Is there an offset to that through getting smarter, having better information, being able to be less duplicative in our service delivery? That's in some ways the underlying question that we're, at the NIC, and obviously your participation in it, are really trying to explore as we go forward over the next year or so, to really see what we can understand from that. So
I should also obviously have mentioned one of the biggest concerns that some of us have, which is an increase in homelessness. That's inevitable when you limit people's ability to get out of economic. And there is some data that shows actually that while historically, when we've done studies of what the factors that drove people into homelessness, healthcare issues and the lack of health insurance and that cost was one of the major drivers. What we're starting to see is a shift toward simply losing your job and not having an income. And that is a very concerning shift, because that's something that we were already bad at, and the problem is just going to be that much larger.
That's a really good segue into Alfonso, and kind of the view of how economics, how social care, how healthcare, I don't want to raise the stakes too high, Alfonso, how you guys are thinking about it, which is different, and we know is different than in many of the ways that we're doing here. So let's come back to that. So how do we address those issues in the inevitable tsunami of demand and need? But let's hear from Alfonso and some of the thoughts and approaches that he can share with us about how the EU and countries outside of the US are actually handling some of this. And so I had the great fortune of actually meeting the prior director of the European Social Network, and he attended one of our conferences a number of years ago, and was just really excited about really trying to share and shift thinking to new ways and different ways of addressing social care and healthcare differently. So recently connected with Alfonso, and he so graciously agreed to talk with us a little bit, get a little acquainted with what's going on across the pond, as it were, although it is after hours, so to speak. So I thank you for making time to join us here. Alfonso, the stage is yours, and Mike will advance slides to support your presentation.
Thank you very much. Can you hear me okay?
Yep.
For now, great. Thank you, Daniel, and thank you, colleagues of Steers for Change and the NIC Collaboration Hub, for your invitation to speak about an issue that, as Karen was saying, is fully global and has impacted social services globally. Now, if you ask me also if I could introduce ESN, the European Social Networks, I'll do this before I start explaining a little bit how the information that we've gathered so far in terms of how COVID-19 has impacted social services across Europe. So if we can start with the first slides, there I explain a little bit about what the European Social Network is. ESN is a network for public social services in Europe. It's mainly for the departments of social services in public authorities. It includes as members directors and professional associations, local and regional authorities, inspection and research agencies, pretty much all of them public, with a public mission. And all of them providing the wide spectrum of services. So this is what sets us apart in a way from other organizations, in the sense that it includes those who manage, those who finance, those who provide and inspect public social services, with a total of 140 member organizations in 35 countries. Now, what do we do? Well, we promote, very similar to what you do, and you mentioned APSA earlier on, and I was very happy to be able to go to their conference last year in October, where I attended their Health and Social Services Summit. And it was a great opportunity to realize that despite the differences when it comes to political considerations, legal considerations, actually the topics, the issues we are looking at are very similar across the US and Europe. Now, so we promote exchange of knowledge and building of that knowledge, and we do so through an annual work program that is co-funded by the European Commission and includes workshops, working groups, seminars, in areas such as integrated support, technology, child protection, long-term care. We have also an annual conference, which is the European Social Services Conference, which this year should have had its 28th edition, and it'll be next year. And we also have a European Social Services Awards, which tries to create excellence in the field. And of course, we support our members. We do some training with them. For example, we have an evidence-based social services training, which in a way was very similar actually to the work that has been done by APSA on the value curve. So yes, a number of similarities there in terms of the way we work. Now, of course, as part of the work that we've been doing over the past months, we've focused on COVID and how COVID-19 has impacted the way social services, public social services work. As you can imagine, this has had a significant impact in Europe. Now, if we can move on to the next slides. Now, what are the social changes? Because COVID-19 has brought a number of social changes, which have then in turn affected provision across Europe in terms of social services. Well, with lockdown measures, family networks have become weaker. There have been difficulties in reaching out to vulnerable families, was mentioned by Karen earlier on. There have been concerns about the well-being and the safety of those children, because what we've seen is, of course, a reduction in the number of calls to helplines, but actually now we are seeing how this is increasing now. While there was an increase in loneliness of older people, because they were told they are still in many respects not able to go out. So either in their own homes or in nursing homes. And I will refer to nursing homes later on in my presentation. In general, we've seen difficulties for the general population as well, and in many cases for those with whom social services work, when it comes to the preventative type of work, either medical checkups, people attending daycare centers, unable to do so because they were closed, social services centers, the same thing, with the impossibility to be able to welcome potential clients and the clients with whom they used to work, because those interventions couldn't take place any longer. Now, if we move on to the next slide, please. What we see is that these changes, of course, have affected the way social services work. From one day to the other, all face-to-face services had to be done on the phone or online. Simple things for which some organizations were just simply not ready, like redirecting the phone line, the office phone line, to a private mobile phone, had to be set up, which meant that for many of those vulnerable people who were using those services, they just couldn't, in some cases, actually be able to link up with their social worker, their case manager. The issue of securing protecting equipment, personal protecting equipment, has been an issue across the board in pretty much all European countries. In some countries more than others, particularly where there is a clear, if I might say, a clear fragmentation, division between health and social, and the difficulties to get personal protective equipment for social carers and social workers has been a very serious issue in a number of countries in Europe. Particularly in those cases also where those professionals were not being designated as essential. In order for them to be able to access that equipment, they had to be designated as essential so that then they could continue carrying out their duties. And of course, a situation which was constantly changing, constantly evolving. And the question for professionals was how to keep up, how for professionals to be able to respond adequately to those changes. So,
if I could just ask a quick question in the moment here. So I'm assuming this is or at least a reflection of many countries that are part of the ESN. And I'm curious to see, is this consistent across countries? Is it more extreme in less affluent countries? Is it just quickly, is there any variability here that we're looking at that would be interesting to know about?
Yeah, I was gonna when I go onto the slide on older people's and care homes, I'm gonna refer to some of the figures on care homes. But for instance, the issue of being able to access protective equipment has been an issue across most European countries. There are some cases which have been particularly serious. If we look at, let's say, the situation of Spain or the situation in the UK. For instance, what happens is you've got a national health service which coordinated the access to personal protective equipment. This meant that mostly that personal protective equipment was sent out to hospitals because they had those needs, and clearly there were very serious situations there. But that meant also that for those who were working, let's say, in care homes or who were working in home care, they had no way to be able to use the general centralized system of the National Health Service, and that meant that they had to go themselves onto the competitive markets with the difficulties to be able to access in the first place because there was just not enough production, but also to be able to pay for that because it was extremely expensive. The issues of, let's say, the reduction in the number of staff is being across the board because basically either staff was getting afraid of becoming infected because they were actually becoming infected. But also there have been some interesting situations which we also received information about in cases in which professionals working in social care were being discharged, were being asked not to go to work because they had some symptoms without actually being done the test, which meant that a significant proportion of them were unable to go to work. But also a number of them going to work in hospital settings, which meant also that the number of professionals working in social care was constantly being reduced during this time, and therefore the number of difficulties to be able to serve the populations with whom they work. So yes, a number of countries, there are some differences between them, but it was actually quite a number of similarities across Europe.
Yeah.
If we move on to the next slide, now this has led to a number of emerging needs. One of the things that obviously social services have had to respond and will have to respond quite a lot over the next months. And you may have heard that, for instance, in Spain, they have approved a minimum vital income scheme to respond to the loss of income of many families, which certainly is a serious issue right now. It'll become even more evident as we go along over the next months. But also the need to cover basic needs like food, medication for those who actually couldn't leave their homes, which has been quite a key task of social services and social care. They need to respond to the needs of vulnerable families and their children in their homes in those situations in which they couldn't be visited, particularly again, if social workers had not been designated as essential workers and couldn't actually carry out their duties visiting the homes of those families. They need to provide emergency responses for homeless people or for those fleeing their homes. I was discussing earlier on with someone, one of the social services consultant in Spain, they were saying that they had created almost 8,000 places for homeless people. Now the question is, because of obviously they couldn't be on the streets, now the question is what's going to happen now? So as COVID sort of things just go back to this new normality, but these people again, they don't have a place to live. So the question is, will this be maintained, or was just only from a crisis point of view? And the need to secure care in a continuum through which has been done somehow by reinforcing home care and telecare, and I'm going to refer to some examples later on. Now, if I go, I'm gonna just, if we go on to the next slide, I'm gonna refer to a couple of population groups, to children and older people. When it comes to children, we recently organized a webinar on child protection with members from Scotland, France, and Italy. I'm just gonna briefly refer to some of the issues that were highlighted during this webinar. Certainly the strains and vulnerable children who cannot be supported by their families during lockdown, and the need there to keep schools open for them. This has happened in some countries, in Belgium, in the UK, schools were kept open for the children of vulnerable families or of essential workers. But still, I mean, here in the UK, in England, for instance, in many cases, just barely 2 to 3% of those children were actually coming to schools. So still, there has been a significant number of them who have remained at home, and we need to see as to what the outcome, the impact of this has been. And of course, the challenges that social services have been facing to reach out to those children who might be at risk, or to maintain contact with children with whom they already were in touch at the beginning of the pandemic when the lockdown started throughout this period. Now, if we continue on to the next slides, in order to address some of this, there have been a number of responses, and very positive ones, actually. We've seen very positive examples within the communities. Our French member was telling us of of initiatives within the communities where they actually open up their child residential facilities to volunteers to come and work with them. They had analyzed a little bit what's the situation and how children in the child protection system coped during the lockdown. And it was felt that those who were in foster families coped better because they were coping as part of the wider family unit. While for those who were in residential facilities, it was much more difficult because of being in lockdown, because of not going to school, because of not being able to go to the doctor. So basically, those residential facilities were their only hope for them 24 hours every 7 days, and that obviously had an impact in their well-being, and we shall see as to how this impacts over the next as things would move forward over the next weeks and months. In Scotland, they were telling us about how, in order to help strained public authorities, volunteers set up helplines with local authorities to support the role of officials in contacting families and speaking to them and see as to how they were. In Italy, they explained how previously face-to-face interventions moved online, and they need to ensure that professionals, of course, were provided with the tools to be able to undertake their tasks, but also to be trained accordingly. And this is not something that can be done in such a short period of time with the immediate of the response to the crisis. Well, of course, again, the importance of considering family social workers as essential so that they are able to carry out their duties, and in order to be able to do this, that they could access protective equipment. Now, in terms of older people, if we move on to the next slide, you're probably aware that, well, you're probably aware of the situation in Europe. This virus has affected particularly older people, especially older people in residential facilities. Figures, we don't have that many figures yet, but figures from Italy, Spain, France, Ireland, and Belgium show that between 42 and 57% of deaths from the virus happened in older people's care homes. This is based on a report from the London School of Economics with academics from the UK and from those European countries. We are still trying to figure out as to what's the situation here in the UK. The number of deaths has increased significantly in France over the past weeks due to adding the number of deaths from care homes. Now, for us, we think that this requires us to rethink the model of residential care for older people. And I believe that this will be one of the key aspects of the work to be done next months and years. Now, countries are starting to audit their residential services. We've requested to the EU that the European Commission looks at this too, working with member states to ensure that funds are put into community care and supporting people to live in their own homes. Now, on a more positive side, there has been a reinforcement, we can say, of some of the care provided at homes. So support for older people in their own homes has been prioritized based on criteria such as the degree of dependency, isolation, and also whether they were attending daycare centers. So they had already been identified because they were going to daycare centers, and then they could be supported in their own homes. How has this taken place? If we move on to the next slide. Well, it was in many places, it was reorganized to focus on personal care, on supervision of the medication, grocery shopping, bringing food and cooking for them at home, reinforcing telephone calls, and providing meals on wheels. For instance, in the Department of Welfare of the City of Madrid, they explained that these services increased up by 23% during the lockdown. It's also included reinforcing telecare. Our member from Barcelona County Council explained that this included not only the alarm buttons that they wear, but also equipment to prevent risks such as fire, gas, smoke detectors, and equipment to identify the presence of someone or potential faults. So if we move on to the final slide, in terms of what are some of the lessons learned, from our perspective, one of the key lessons learned is the need to have a coordinated response, certainly between health and social care. And this means reinforcing primary care in the community. Reinforcing primary community care is key both in health and social, and this be linked up with hospital care. The second element is about the digitization, because and we see this as a wider as part of a wider emergency preparedness plans, ensuring that processes have been digitalized so that professionals can carry out their tasks remotely. And of course, it's about ensuring that social services professionals have access to the equipment they need, that they are considered as and designated as essential workers, healthcare, to be able to carry out their duties. And we also see over the next months the need to reinforce social services, because they will have to take care of an increasing number of women, children, and families that will need a significant amount of support. Thank you.
Thank you very much, Alfonso. That's great. Before we move to PG, I just want to open it up. Just is there any immediate response or question? While you're thinking, one of the things you mentioned on this slide here is that coordinated response between social and health, and how that actually happens. I think one of the things that we'll explore a little bit shortly is that separation in the US about you've got your healthcare system and you've got your social human services care system. And the two oftentimes have difficulty sort of coordinating, because they're just the whole structure and the way that they're organized is so very different. I think when we were speaking previously, you were saying that that the actual structure by country is actually different than what we're maybe used to here. I don't know if there's a particular insight that you have around that is providing more help or more success in that area.
I think that, as you say, this fragmentation or this separation between health and social services is not actually something that just happens in the US and doesn't happen in other countries. And actually, we do have this in several countries in Europe, and not just several countries, not just at national level, but even within countries themselves. We have a number of countries where where health and social are decentralized, and actually, even though there are some general common framework, particularly in health, then the situation actually changes when it comes to how this is actually being implemented in each region. So there are different approaches to this. We have had situations in which, for instance, in Scotland, for example, they decided to actually legislate to ensure that there were agencies, new agencies created, and where certain specific responsibilities of social care, which is the duty of local authorities, are passed on to these agencies, and the same with certain responsibilities for the health service. This has been mainly the case for adults, for all the adults with complex needs. Then you've got situations like the Nordic countries where actually, when it comes to primary care level, you've got there a good coordination between health and social, in many cases, because actually the local authorities themselves are responsible for the provision of primary health and social care and social services as well, and in many cases even education and employment, while then specialist health services are more the responsibility of the county level, but still you get a good link between the primary level and the specialist healthcare. So I think there is where you need to look at. Also, a lot of this depends on the traditions of the countries as well, and how they see certain things, on how developed their systems are. For instance, sometimes we talk about the need to integrate health and social, but actually you've got a significant difference between how health and healthcare has been developed, and then social services and social care, with very weak social services and social care services. I wouldn't even call them systems, and then a much stronger healthcare and health sector. And therefore, you need to come to a way of sort of coming together, because otherwise it's just going to be very difficult for the sectors to be able to coordinate and integrate in a better way. But really, what we need to think about is the person, putting the person in the middle and making sure that services are actually designated to support and to work around the person. So I think we need to look at the differences between those countries to actually try to pick up the best of each one of them and try to bring it together, having always the person in the center of our minds, really, I'd say.
Well, one question I'll tee up that James just put into the chat here is, and this may be going to a slightly longer conversation, and which we can engage with after PG. But are there any particular approaches from a technology perspective, or databases, or sharing of information that facilitate that, or is it really a country by country effort in terms of really developing the infrastructure of the systems to be able to share that information about the person in the center?
Between health and social at European level, there is nothing like this. So it really is country by country. Not only this, is actually depends, it's even within the countries, it actually depends on the country, and sometimes there are differences between the regions or between localities themselves. We do have examples of systems, you call it in the US interoperability, the integrated systems platforms, where you've got health data and social data, trying to bring them to actually talk to each other. And this is developing, because the thing is that the health service has been quite advanced in that respect. So a lot of work has been done there in terms of ensuring that there are a number of criteria, of indicators, that then you've got data. In many cases, this data is actually related to a number. Each person is allocated a certain number or an ID number. to which the data is allocated. And then what you've got is the social, however, this did not include necessarily the social area, no? All the aspects related to social inclusion, social cohesion. And what we've seen is in a number of countries developing that area. And now what we are trying to see is as to how they can actually talk to each other. But there's nothing like this at European level. And at national level, it depends on the country, and not necessarily looking at a national, but more depending on the regions and the localities. So, so I would say that this is something to look at, and of course there are certain differences between countries as well.
Sure. So maybe that's a great place, maybe of coordination of efforts as we look at it, because that's certainly a drive in the U.S. is to figure out how to get a more comprehensive, consolidated view of a person or a family that brings in the various data streams. So you have in one view, so to speak, a consolidated view. So we can explore. Let's continue to explore that. But let me sort of segue now over to PG. And what PG does best is sort of both to synthesize, but also to provide a sort of a policy framework and a construct for us to think about health and social care, which I'm always very thankful for your articulation of that, living in both systems, both the US and Canada and in Europe. So with that, PG, the floor is yours.
Thank you. Well, yeah, very happy to be back, and it's a tough act to follow both Karen and Alfonso. So much information to digest, really stunning and very strong presentations. Could we see my slides, please? Yeah, we could go to the other one. This is just, what we learned, like what I learned actually. So Danielle asked me to start by going back to some material I shared with you in the past on other webinars. And of course, I've been working with Danielle and Steward of Change now for 6 or 7 years. So we had this constant conversation about those issues. But so basically, one of the things on which I've been working recently is trying to understand better how countries that have been not completely successful, of course, but that have at least attempted to find a way of bridging social and healthcare, social services and healthcare, and so on and so forth. How have they tried to answer this question? How have they tried to organize themselves? And I came with this idea recently that finally you could identify 3 major principles. Some countries have been essentially trying to do that with in mind the idea that their final goal is integration of as many people as possible in the social and economic life of the nation. One of my favorite examples is, in my home province of Quebec in Canada, we have a universal daycare regime. You won't believe it. You have subsidized daycare at $7 a day, paid by taxpayers. And this regime has been created for one purpose, to make possible the highest rate of participation in the workforce of women in North America. And it has worked, and it has had immense positive impact on the health of children and on the health of women as well. And I think this is a very good example of this idea of integration as the most important principle in looking at as what I call bridging health and social care. The other possibility is this idea that what you want is facilitate participation of everybody, people with vulnerabilities, people that have disabilities, and so on and so forth, elderly, and our data at this moment, and this is very much in line with what Alfonso just presented, our data at this moment is showing us that for reasons we don't understand yet, the countries that have fared the best at this moment with COVID-19 are countries that were pursuing this particular objective as their main objective of participation. And finally, the third perspective that has emerged in recent decades in the US, very clear. This has been Bernie Sanders, for instance, demand, and I'm thinking also Elizabeth Warren, most of the left of the Democratic Party, has been this idea that this has to do with citizenship. And you will find, a record of Sanders, for instance, constantly coming back to healthcare as a right of citizenship and so on and so forth. My message is that we may not have to pick one of the three, but I think that if we want to move the needle in the United States in terms of better integration between social and healthcare, we cannot avoid a conversation about those high-level principles, because at this moment, if this is not something for today, but if I were to do an analysis of the different movements that are advocating for integration, you will see that some of them are pursuing this objective of citizenship, others and participation, and depending on what is your main objectives, the type of policies or programs you're advocating for will be quite different. So building a large coalition will require some sort of conversation. Next slides, please. So this is another thing on which I have commented many times. What makes the U.S. exceptional? This time, not in the good sense of the word, but in a more critical sense. It's those particular traits of the health system and the social system in the U.S. The fact that you have this big wall that has been built between healthcare and social care. Daniel shown you at the start the level of expenditures in healthcare, and the fact that you have completely two different worlds with different professionals, different expectations, and different level of funding. The fact that there is, for cultural reasons that I understand, but also for institutional and structural reasons, a very important tension between what is called social provision of services, so services that are provided essentially by public authority, and the idea that the market is more efficient and people will want to keep the capacity to choose and in between providers in the competitive market. The fact that we cannot ignore that each time you're mentioning social policy in the United States, the first thing that come forward are issues of race and poverty. And of course, federalism has shown that we are dealing with COVID. We have benefited in some way from a federal structure, but in the same time, it means that there is a lot of fragmentation in terms of authority and a large and big fracture in terms of the decision-making capacity to create those bridges and connections. Next slides. So what I would like to do is show you just for a few minutes what happened in Canada, because I think there is a few lessons from the Canadian situation. And what I will try to do first is to share my screen, which, as you know, on Zoom is sometimes more, you see at this moment, Sundays don't let me share my screen. So thank you so much. So So Sundays, you will have to do it for me because I'm not authorized to do it.
You have to just make him the co-host.
Oh, I'm sorry. I'm sorry. I had to activate allow multiple shares. Try it one more time, PG.
Okay, I'll see if I could do that way. Yes, here. Thank you so much. So this is a website that we have created between my school and the School of Medicine here in Calgary, essentially to support we were providing advice to governments at the provincial and federal level and municipal level in Canada. So we built that as essentially as a tool. You could go there. It's very interactive, very interesting to start testing hypotheses. So this is the state of the pandemic in Canada as we speak. You could see that we are around 80, of today 95 0.75 cases in the country. The thing that, so if you compare with the US, you remember Canada is 10 times smaller than the United States. So if you correct for population, we are about at 60% of the US situation in terms of cases and 50% in terms of fatalities. And one of my hypotheses at this moment is that it is in part the result of our institutions, in particular universal healthcare, that has helped us address the problem of very vulnerable people during the pandemic, because there was no barriers for the use of healthcare, but also of a certain number of policies that have been put in place in Canada for a long time to reduce, not in a way that is spectacular, but still when compared with the US, that have been important in reducing inequalities in the country, and that played a role. You see that on the left-hand side of the screen that there has been huge differences between provinces. And this is also very interesting in many ways, because it has forced us to say there is not a Canadian response. And this is very close to what Karen presented about the US earlier. There is not a Canadian response to the pandemic. There has been different situation depending on the province, which are, as you know, state equivalent in Canada, with the two larger provinces, Ontario and Quebec, it the most. And it 84% of the cases are in Quebec or Ontario, and 94% of the deaths have been in Quebec or Ontario, most of them in long-term care institutions. So you have to start asking you a series of questions about what happened there. The way we did this, and this is probably for a non-Canadian audience, the most interesting part of that website, is this is a website comparing the story of the epidemic in a very, very large number of countries of the world, including in Canada, the provinces. Unfortunately, we haven't done the work on discrete American states, but you will be able to compare. This is Canada. This is, for instance, my province. I'm trying to, the Netherlands. I think I have Spain somewhere, France here, Spain somewhere, Germany, and so on. And so you could compare the story of the pandemic in each of these countries. But you say, we have seen tons of websites like these. The interesting part are those little dots that you will find there, that on the curves, that will give you an idea of all the policies, programs, and interventions that countries have put in place to try to manage or mitigate the outbreak. And there is no places where you will find that kind of information. And one of the things you will see, when I spend a lot of hours looking at these data, I came to the conclusion that when it went very bad, it's a mix between three factors. Bad decisions, very clearly, and bad decisions have been made in many places. The delaying the moment where we start banning travels and so on and so forth. Most importantly, the legacy of bad policies. And again, the point that Alfonso made and that I made about participation and faring better, it's very evident for when you look at the death rates for elderly, countries that have had in place for a long time, like Denmark, policies that were done to encourage the participation of aging population into society with programs at local and regional levels and so on, have all fared better in terms of the way they have reacted to the pandemic. And we could show that here. So bad decisions, bad policies, and of course, bad luck. The fact is that New York and Quebec, for instance, have started understanding that asymptomatic people and travel were a big factor in the dispersion of the virus in the population much too late. And it was already, the virus was already dispersed very widely in the population when people started understanding this problem. institutions have played a role, but they have not been a substitute for good decisions. You know, as I said at the beginning, it's not a bad, it's better to have a universal health system because people will not avoid going to the hospital, but it's, or being tested and so on and so forth. But during the pandemic, it was very important to have people that were able to make the good decision and at the right time. And leadership itself could be, it is a very important variable, but you need leaders with good judgment. And so it's not enough to have people that are able to parade in front of the media and being fun and entertaining. We had a few of those in Canada, but in the end, if they're not able to make the good decisions at the right time, it has been a disaster. So we could go back to the, I will stop sharing and we could go back to the slides on this, please, or Michael. You should have used that time for a commercial. So no, further down, yeah, let's go down again.
Oh,
Next,
there you go.
next. This is what I just mentioned. Next slide, please. Okay, this is my conclusion. So, you know, I want to go back to a few things I think I have learned and have heard the hard way during those last 10 or 11 weeks now. And I think those are very important lessons for the future and for the work we want to do together. We're planning a big conference in next January. And I think that for me, this is guiding my thinking at this moment about the things we need to discuss. The first thing is that despite everything I told you, my intuition at this moment, and I have data to prove it, is that even the best decisions cannot redeem bad policies. And that therefore there is a very important agenda for us all in starting thinking how we develop and how we implement better policies. And again, the example of what happened with the elderly all over the world, not only in the US, not only in Canada, but all over the world, we have learned the hard way that bad policies that have put the elderly on the margin of society, that have parked them in underfunded long-term care institutions with badly paid personnel and so on and so forth. This is the price we have paid during the pandemic is incredibly high. You may have seen this very good study that came from New York showing that the people that have died have on average lost between 10 and 13 years of life. So of course they were old, but they have lost 10 or 13 years of life. And why? Because of bad policy choices in the past. So I think there is a huge responsibility for us all there. We have learned that there is no quick fixes, and in particular for inequalities. One of the big lessons of the pandemic for me, and you may disagree, is that, finally, AI didn't play any role in managing the outbreak. It was completely marginal. The tracing apps and all this, distraction. This is not how we have been able to control the outbreaks and control the clusters where we're seeing a highly contagious individual and we're facing problems on the ground. And this again, I think there's a need to revisit a lot of things we have told ourselves about the way technology will save us in the future. And again, this is part, I think, of our agenda for the future. Something that you will find, I think what we have learned is that we don't know what to do. If you go back to my slides, no, don't do it, but just virtually in your mind to those curves where we have put all those interventions. Go to the curve for Italy or Spain. Those countries have thrown at the pandemic everything they had, and they were not able to do much. And so we realized that a lot of things we were taking for granted in terms of the right public health interventions, in type of the right policy interventions, seems not to have worked very well. And I think that at this moment, I have been part of numerous panels where people come and say, I know what to do. And I'm able to show them that country A, country B, country C have tried that and it didn't work. So I think at this moment, there is the need for a completely new research agenda. And this again is something we're trying to achieve with the conference in January. And of course, I don't want to sound negative. You know, I think that we have also learned during the pandemic that it's better to be late than dumb, than not doing anything. And that in fact, you know, in each place, interventions have saved lives. That we have been able to basically protect people, which it could have been a much more dramatic and catastrophe than the one we have faced, in part because people on the ground, public health authorities, and in most places governments, not everywhere, but in most places governments, have tried in the end to do something you know, concrete and to try to mitigate the impact of what has been, you know, for the moment, one of the most terrible experience we have had in public health for a very, very long time. Thank you very much for your attention. And of course, I'm happy to entertain questions.
Thank you, PG. Thank you, Alfonso. Thank you, Karen. I think you presented a lot of food for thought here. And I appreciate you taking time to point that out. I would like to open the floor, or I will open the floor for other commentary or questions or thoughts. There are a few comments in the chat here. I have a couple questions, but let me just pause for a moment and see if there's any particular response. Karen, you were just talking about you were cheering on "We don't know what to do," and from the official public health perspective, that's a little frightening.
But it's true.
Well,
You know, we know some things that are working, but I think PG's more important even than "we don't know what to do" is we can figure it out. We just have to think about it differently and not sort of do a retry. It's not pull out our pandemic plans that we developed first for smallpox and then for pan flu and then for H1 and now and then SARS and then now this. This is the first time we had to use all of the tools in that toolbox, and they helped, but the consequences of them, particularly mitigation, have been extreme. And some of them just don't work at all. We also ran into the reality of it's well and good to say something on paper, but unless you really think about the real life consequences of those things, you can't actually plan to use them, at least not in an intelligent way. And I don't want any of us to be caught that flat-footed again. And there will be an again, just in case anybody thinks that this is the last pandemic.
I totally agree.
so I guess the question that is on the top of my mind is so what is next? I mean, that's the question that we're calling in terms of the action agenda that I spoke about at the very beginning. You know, we don't have the luxury of like saying, okay, we'll wait for another 6 months, do an assessment, do a retroactive assessment, figure out what we've got to do. It feels to me that we need to be able to react in real time, learning what's happening, sort of this emergent thinking, and to be able to test policies or test thinking about what would both prepare us for the inevitable and or what we can do to mitigate going forward, both in the short term and the long term. So I put that out there.
I want to weigh in just really quickly. I don't want to, dominate, but I think that the kind of analysis that PG showed us, and I'm going to have to go back and grab that link because that's really important, is something we don't typically do. And we also have modeling capabilities that we never had before. And what's more, we're able to model from real life now. Not make up all the indicators. So we need to start looking at the full context of what people did or didn't do and comparing what worked and what didn't work. But then also analyzing the determinants of where did it work and who did it work for, and what was the background. So it really does. Somebody, Ruth put up policy analysts. I agree that we don't include policy analysts much. We have, you got technology geeks doing lots of modeling, and you've got infectious disease experts doing lots of modeling. But this is an opportunity to really call out a cross-sector group of people getting together. I mean, really, to say what should we be looking at? We've got tools that we can use to look at them, but we don't even know how to begin to do that because we're all in our little silos.
I'd like to just echo that. I think what Karen is saying, and really what PJ suggested, is that this issue of policy development has to be a starting place. Too often we get bogged down in the nitty-gritty details of what our information systems are going to do, or what we're going to do to react in the moment to a particular situation, without thinking through the why and the rationale for developing a policy that deals with the capability to respond to situations like this. And somehow we have to focus more on the policy side of this than just the nitty-gritty details of how we respond to this kind of event.
I want to just call out Eric Jan's comment in the comment bar here, but for two reasons. One is the NIC is in fact thinking about this. It's really in many ways, Paul and Karen, all of you, from a systems perspective, how do we bring systems thinking to this? Because the issues are so clearly affecting multiple different domains at the same time. That's not a usual behavior. That's not the way we train. That's not the way we educate. That's not the way we work. That's not the way we generally remunerate. It's usually the specialization that our societies now have been considering as the most vital contributor. And while that's obviously critically important, it's that cross-sector and cross-system kind of approach. And so, Eric, I don't know if you're on the phone, you want to say a little bit more about that, but for those of you who have not visited the NIC site yet, there's a lot of work going on around trying to model some of this stuff and trying to really think broadly about some of these topics.
Thank you, Daniel. Yeah, I just wanted to highlight that we're looking at, there are cross-sector models already. NEAM is one, a great one. But what we're looking at doing first is identifying all the health and human services models out there already, and then identifying gaps and looking to harmonize, as future tasks, but really not trying to reinvent anything at first, but just figuring out, what do we have? What is the most needed thing that we should work on mapping or linking or creating first, and then going from there. But not just on a US basis, but worldwide if possible, because there are great ontologies out there worldwide that we can start with as well.
Exactly, bravo.
So we invite you into those conversations, and I'm so glad to invite Alfonso into the conversation. And if by chance we are able to bring people together, and hopefully we will, late January, we will be meeting in person in Palo Alto at Stanford to really think about these system efforts. We do have an alternative date, and we do have an alternative online option, but it would be pretty awesome to bring people together to really think about this, not to start the conversation, but to synthesize the conversation. So what we've proposed is a series of work groups over the next 8 months to focus in on various components, whether or not it's policy or technology or privacy or ethical use of data, or the research agenda, what we know, what we don't know, and what we should be knowing. And so come join that, come add your voice to that, because I think that we have that unique moment in time to actually make that change happen. or at least to represent what we ought to do, even if it's a few very specific policy related kinds of things as we go forward. And so just in the last couple minutes, I want to just remind people next week about Marianne's presentation, which is part of in the US, the federal initiative. And Mike, if you can go forward one more slide here, I think, yeah. So I just wanted to finish on this, which is to address this whole issue of systems thinking. Stewards has been thinking about this for quite a while. And we have been, again, with support from Kresge Foundation, able to put together our training program that thinks about how do you apply systems thinking to this complex world of multiple domains trying to affect it. And we call that interoperability. This has been an ongoing process, but we are expecting to launch this program in beginning of July with the first cohort. So you'll be seeing more about it on the NIC site and the SOCI site. We'll be taking some applications to generate this first cohort, and then it'll be also open to everybody to join. And the idea is to create a curriculum that is emergent, that is responsive to the demands as they evolve, and that is grounded in systems engineering thinking. And so keep your eyes open for that as we go forward. And with that, I want to thank our presenters and our colleagues and the folks who have carved out time again today to bring some new topics together. But we do have an open survey on SurveyMonkey that we seek your thoughts and feedback and recommendations. And if you want to participate, there's a place there to say, yeah, sign me up. And we will immediately get in contact with you if you so want that. Stay tuned for other interesting events at the hub, and I wish all of you health and well-being and safety and some fun this coming weekend. And with that, I will adjourn today's Let's Get Technical call. Thank you all so much for your time and attention. And Alfonso, thank you again for making time today. I look forward to checking in with you and seeing how we can connect with ESN and the work we're doing here, Canada, and the rest of the world. So with that, be well, everyone. Thank you so much. Have a great weekend.